Hello, everyone. I'm hoping that you can see me here. Can I just get a confirmation from the panelists, please?
Yes.
Fantastic. So, everyone, we're all in a really uncertain context for all of us. None of us have ever been in a situation like this before. We're trying to understand vast quantities of new information. We're separated from each other, and most of us aren't specialties in everything we need to be to try and understand it. So today we're here with Julie and Ruanne, with the aim to hopefully hear from a couple of frontline doctors working in public health and research and infectious diseases, and have a chance to ask them some questions about their current experiences over in the United States. The way that we're going to run this today is we're going to have a couple of questions that some of you have already started answering on Mentimeter, which involves going to the link up at the top of the holding slide and using that code so that we can get an indication of who we're talking to. Once we've run through those first slides, we'll get a quick introduction and an idea of who Julie and Ruanne are and what they're passionate about. And then we'll have an ongoing chance to ask questions. I've got some of my own, and I imagine you have plenty of yours. Those questions will come in both primarily via the Mentimeter link up at the top. And if you have any trouble with that, then you're welcome to ask questions using the question and answer feature at the bottom of the Zoom. At some points, Julie and Ruanne have expressed a desire to perhaps hear from you. So if there is an appropriate time, we might ask you to use the hands up feature, which involves clicking on the participants button and putting your hand up. And we might ask you to share a bit of your own insight. If you do that, please bear in mind we are recording the session today. So if you don't want to appear in the recording, please use the question and answer option rather than raising your hand to speak. A couple of other tips: please don't take any screenshots or audio recordings of this session. We are officially recording it. As attendees, your microphone is muted and your video is off. So please use the question and answer on Mentimeter primarily, otherwise at the bottom of the Zoom. And we will have a fantastic session. I should say quickly before we start that my name is Oscar Lyons. I'm one of the Rhodes Scholar Program facilitators. I'm a doctor from New Zealand, and I am studying leadership development here at Oxford and hopefully helping everything run nice and smoothly today. So let's have an idea of who you are. So we've got a huge number of other here, which means we have probably not asked the right question. If you want to pop in the question part of the next slide, who you are and what we're missing here, that would be fantastic. I also note we've only got 16 of you so far, and so a couple more would be fantastic. Again, if you go to the link up the top, menti.com, using your phone or another laptop or the one you're on, and use that code, we'll get an answer from you. I might pop back to that if we need to. Fantastic. So I think Julie and Ruanne have had a little bit of a read of this as well. So they're getting a bit of an idea of what you would like to get out of this. So I might leave this slide up for a minute while we hear some introductions from Julie and Ruanne, and then I will hide this from view so that you can see nice big pictures of them both. Perhaps Julie first, if we might. Julie, could you tell us a little bit about who you are, maybe a bit of your history, where you've come from, what your current role is, and maybe a little about what you're passionate about?
Thank you. And I'm so grateful to be reconnected and connected with all of you in this space. I grew up in Philadelphia, which is a city in Pennsylvania, the United States. I was at Oxford 98 to 2000 at Wadham College, studying economic and social history as an MPhil. My undergraduate degree was at Wellesley College, also in history. So I went into medicine with more of a historical and public health orientation. I think it's notable to mention at Oxford that my thesis work turns out to be quite relevant now, because I was very interested in how, in social responses to disease. And the model that I developed now about 20 years ago was thinking about notions of quarantine and isolation for infectious diseases. Then it was the model of leprosy control in Puerto Rico, which is an island and a territory of the United States, but framed a very interesting model about thinking about hegemony and colonialism, and how public health and science are shaped by broader macro factors. I went on to do medical training, infectious diseases, specialty training, and now co-direct a community research program of about 200 plus professionals. Were made of interprofessional group, physical therapists, internal medicine physicians, surgeons, speech language pathology, emergency room medics, all trying to triangulate community-based health problems as perceived predominantly by the community in which we sit, which is Chelsea, Massachusetts, and I'll talk a little bit later about the problems. Chelsea is now has the highest case count of COVID-19 in the state of Massachusetts, and ranks with the New York State average for case count. So it's a very troubling but interesting and important model of around COVID-19. I have an infectious disease clinic there, so I see outpatients, predominantly very multicultural population. My research has mostly been, for the last 20 years, focused after the historical work that I did in Oxford, moved into HIV, and that's where I really began developing an interest in community health models, thinking about the need for cultural and linguistic adaptation. And so our program really focuses on Latinos and multicultural populations in Massachusetts who have HIV, who are disproportionately affected by this infectious disease. We've developed some novel health communication tools, specifically soap opera-like designs and multimedia platforms to promote problem solving for patients and engage them in care. And then we have subsequently and are now in Puerto Rico with longstanding collaborations to improve adherence to pediatric Zika care for congenitally exposed infants. So I'll stop there. I think I'm really looking forward to talking about how what we've learned before positions us to think a little bit differently about COVID-19. I'm looking forward to hearing the perspectives of the audience and hear from my old friend Ruanne, who we used to sit on the Oxford Tube bus together in Oxford thinking about many of these problems before. So it's really a pleasure to be with you all.
Thank you very much for that, Julie. And so we might pass to Ruanne. If you could answer the same things just to start with, Ruanne. So who you are, your history, what you currently do, and what you're passionate about.
Great. Thanks so much, Oscar. And thank you for this wonderful invitation. It's a real privilege to be back at Oxford, even if it's virtually. Julie and I were good friends while we were there and continue to be, and our lives have taken very similar paths. So my name is Ruanne Barnabas. I'm an associate professor of global health and medicine at the University of Washington. I am South African, so I came to Oxford in 1999 as the KwaZulu-Natal and Merton Rhodes Scholar. And even though South Africa had over 1,000 Rhodes Scholars by that time, women were still in the double digits. So I was really happy to have that opportunity. I'm an infectious disease physician and I attend on the HIV service inpatient and outpatient here in Seattle. And a lot of my work is focused on HIV, STIs, and other infectious diseases, and now including COVID-19. Work is twofold. One, to generate high quality evidence for interventions that work to prevent disability and death. And then the second main focus of my work is to make it as easy as possible for clients to access that care. So a lot of my work is around differentiated services to remove barriers to care for people living with HIV in Southern Africa. One of my main projects currently is a home delivery service for antiretroviral therapy. And recently we showed that community-based services for HIV eliminate the disparities in access to care. So we were able to show equal success for ART services for men and women and across all age groups in Southern Africa using community-based services. And the hypothesis here is that community-based services can overcome the barriers to care. In another study that I lead, we are estimating the efficacy of single-dose HPV vaccination to prevent HPV infection, which causes cervical cancer. Currently, 2 or 3 doses are recommended depending on the age of the individual, but there's compelling evidence that only a single dose might be sufficient. And so this would be game-changing for making vaccination available in low and middle income countries, and especially where there aren't platforms for adolescent care. For COVID-19, we are focusing on looking at interventions to prevent COVID-19 transmission. And so I'm leading a COVID-19 post-exposure prophylaxis study, a PEP study, to prevent transmission within communities for COVID-19. And I'm sure many people have heard about hydroxychloroquine, a medication for which there is encouraging laboratory evidence and some limited encouraging clinical evidence, but for which we don't have rigorous scientific data supporting the use of hydroxychloroquine. We're testing that as a post-exposure prophylaxis intervention for COVID-19. The main focus of our work does its best to overlap with what Julie is doing in communities. And so we are also now focusing on reaching communities where disparities are marked and where we expect and are starting to see more COVID-19 infections. So that is also a priority for my work. I lead an energetic group of students and postdocs and fellows, and we're part of the International Clinical Research Center, which is an outstanding place for all of us to be. We're very well supported in our work at the University of Washington. And everyone, we always thought we worked hard, but COVID-19 is bringing out the best in scientists and providers in terms of both responding locally and thinking about how we can generate good science at the same time.
Thank you very much, Ruanne. I've noticed some similarities linking through both of your introductions, and particularly there's something about equity of care and involvement of communities. I wonder if Julie might have a response or something that she'd like to ask you about with that, Ruanne.
Can you repeat the question, Oscar? I'm sorry, I couldn't hear that.
So I noticed you were both talking about equity and access to care. Perhaps I could be more specific and ask you what you have seen, what your experiences have been over the last months, specifically thinking about equity of care and communities at this time.
That's excellent. So, you know, we're not, for those of us who are really embedded in community care, we're not surprised to see the emergence now that race and ethnicity data have emerged about the significant disparities, particularly with Black African American populations and Latinos. I think, mentioning the example of the city that I work in. So Chelsea is a peri-urban city that abuts Boston. It's an interesting case study because I think it can be informative for other similar geographic settings. So we're highly dense population of 40,000 individuals. 60% are Latino. Half of the city is non-US born, and 80% are essential workers. So this really set the foreground for wildfire, for a respiratory illness where 80% of cases are either asymptomatic, no symptoms, or mild. Many of the households are intergenerational households where they're elderly individuals and small children who may be having mild symptoms to none that are passing them on to the grandparents who are taking care of them. And social distancing is really a luxury. And so the workforce of our city has been essentially unable to, or I should say, having quite challenges in adhering to the public health guidance because they're either required and by their financial status need to maintain their work, or just are unable to by the physical circumstances. When you look at the what we consider are the pre-existing conditions that are risk factors for COVID-19, the U.S. guidelines were not upfront in saying or demarcating the social and economic circumstances that place people at risk. I know other countries like Canada have explicated those, but we know that those are driving them tremendously. So the equity issues are upfront and forefront in the data, but also in those of us who are managing these patients, trying to mount a public health response. I think the last thing I'll mention is that testing, which has been scarce, has really been in most settings consolidated to hospital acute settings. And it really in some ways is counterintuitive, though I understand why it is that way, because we really need to drive these testing initiatives out into the community, because the assumption is that people will come to care. But I think as Ruanne's work has beautifully shown that, what we're showing as well with HIV and the need for community health worker approach, when individuals have multiple competing burdens that outweigh the priority of coming to healthcare, we really need to bring the services and decrease the activation barrier, so to speak, to make it easier for people to decrease the friction so that they can more easily glide into services. And so I'm really curious and excited to hear about what's happening in Seattle with Ruanne's work. We've started mobile testing just in the past week here. I work at Mass General Hospital, which has the largest volume of COVID-19 patients in our state. We have 3 respiratory infection clinics. So essentially what happened was that all of the hospital ramped down non-essential services, and clinical services were then converted to acute care needs, and all of the ambulatory practices were converted into prepared for respiratory infection. So we have 3 respiratory infection clinics, and our entire health center, which treats about 50,000 individuals per year, became a respiratory infection clinic. So the last thing I'll note on that point is it creates a major challenge for public health, because you have to serve 2 needs. One are the acute and reactive to the crisis, but then you have the basal chronic disease care that needs to be met, and is challenged now because all of those services traditionally given in a face-to-face encounter are delayed. And we're trying to ramp up telehealth, but that also makes an assumption that populations are ready for telehealth. And often we are finding in the survey work that we're doing that patients are interested but need help in capacity building for being able to get online, particularly in more elderly populations that need help with accessing a smartphone or using video capability.
Thanks so much, Julie. Maybe I'll respond directly to some of the questions that you asked. Seattle was the location for one of the first deaths for COVID-19. And I say one of the first locations because I think the lack of testing meant that we were not testing widely enough. There could have been other deaths that were not, where people were not tested, and we don't know for sure. But the first reported death was here in the United States, was here in Seattle. And in fact, it wasn't a surprise to us as infectious disease doctors. We had started in the fall. Helen Chu was leading the Seattle flu study, which is a community-based surveillance study for respiratory viruses. And when she noticed that, and when the WHO announced that the COVID-19 epidemic, that the COVID-19 was an epidemic, and that we could see the number of cases in Wuhan and then the cases spreading, she started conducting testing for SARS-CoV-2, as the virus that causes COVID-19 is known. And actually, the federal government discouraged her from doing the testing because it hadn't been approved yet, but she did find then very early evidence of community transmission. And we were in the fortuitous position that we had community surveillance ongoing. This was surveillance for influenza, but we had respiratory swabs and we had the capacity to do testing. So we knew early on that there was community spread of SARS-CoV-2. So we were able to institute very early control measures. And I think this is the 6th week of us staying at home. We can hardly remember what life was like. But there were intense and required movement and physical distancing from our governor, and the hospital switched to then conducting mostly COVID-19 work. We stopped all elective surgeries like many places have done. We moved to telemedicine or telephone visits as much as we could to limit our patient exposure to COVID-19. And so now we have flattened the curve and our epidemic peak is behind us, but we are seeing the virus move into communities where we have marked disparities. So all those measures, as Julie said, have been successful overall, especially for people who have the luxury of physical distancing and staying at home. But for all the essential, we need to see new cases, areas where there's marked economic and social disparities. So now we are shifting our focus. With infectious disease spread, no matter how quick we are, I can't escape the feeling that we're always one step behind, that we should have known from other infectious diseases that this would happen, and we should have started community testing earlier. We did start drive-through testing about a month ago, so I'm happy we did that, but the locations could have been different. And when we look at some of the criteria, of course, we first opened it up to healthcare workers, and now it's more general testing, but we should have moved more quickly. And of course, testing capacity was limited. But I am proud of the scientists who work quickly to develop the tests, to do SARS-CoV-2 testing, to develop in-house assays, to have drive-through testing and other community-based testing. And that has helped us immensely. But I think the key takeaway from this is that disease surveillance is really important. We were conducting surveillance for the flu, but it actually turned out to be surveillance for COVID-19, and we won't know unless we look. So testing, widespread testing, not only community-based testing for people with symptoms, but surveillance is really key for us to, as we start thinking about lifting some of the restrictions this idea of making things as simple as possible for clients to access care, and the work that's being done around this has received a real boost from COVID-19. So it's taken us 5 years to get telephone visits and telemedicine, and then suddenly within a week, we all had that capability set up, and people calling to make the appointments and really stepping in to help with the capacity building for this. So that has been wonderful to see. And in fact, while research has ground to a halt in many places, the project that we have ongoing for home delivery of antiretroviral therapy in rural and peri-urban South Africa continues with the blessing of the Department of Health, because we are removing the risk of patients and people living with HIV coming to the clinic and waiting in the waiting rooms to pick up their medications. And so they've asked us to continue to deliver medications and continue to do our phone-based surveys with our research participants. And we have been on this long ongoing saga asking for multi-month refills to limit the number of visits we do to participants. And of course, with COVID-19, they have agreed immediately that everyone can receive 3 months of medication. And so a lot of those hard-fought battles for us to do client-centered ART delivery have been, a lot of those barriers have fallen in this era of providing medical services during a pandemic.
Wonderfully, Ruanne, you have already done a really fantastic job at answering a few of the questions that have come up. And there is one particular one that was particularly relevant to what you're talking about there. That says, what do you see as the unintended consequences of the COVID-19 response in the US on investment in public health, in vaccines, and in minorities? And it sounds like you've already talked about a possible benefit as well as some of the possible negative consequences. Would you like to speak a little more on that?
Yes, so certainly through this pandemic, we must remain focused on understanding the epidemic and generating evidence. We have hypotheses about what we think is going to happen next and where we think the epidemic is going to go, but we do need the evidence, and we need to start thinking quickly about how we will address those disparities. So studies that will focus on broadening the net for testing and then linking people to care. So I think both those steps are necessary, not just the surveillance, but also then testing what potential solutions are. We need good science, and we need the good science to be done quickly. So we can't wait to do traditional first observation and then secondary intervention. We need to move quickly to link observation and focused intervention, and in a way that is responsive to what is being seen. So in our own work, where we are starting to do testing, we have generated every day, where we look at the baseline characteristics, as we say formally in epidemiology, that just tells us who is getting infection and where, and we start thinking about how we need to change our operations in order to address those needs. And so that, I think, is key. And I'm sure that Julie is really the expert here, so I'm sure she has.
I would just echo what Ruanne is saying and really underscore, in the US in the last 10 years, we've seen a marked decline and retraction of the public health infrastructure, which really, even in the best of circumstances, let's say our plans were well laid out from the get-go, we really we're missing a lot of the scaffold in terms of human power to be able to execute a lot of these initiatives. So I think one, thinking about preemptively the need, and this is so hard, that's the hard thing about our cells, so to speak, with infectious diseases and public health is, unless you have a moment like the Flint crisis in Michigan, where lead came into the water and became an emergency crisis, particularly affecting populations of color. Until something becomes immediately apparent, it's a harder sell to to put in the dollars into the health promotion. So we pay on average 3 cents for every dollar goes to public health investment. So, I think in terms of secondary effects of this crisis is how we can take on a whole of society approach in thinking about public health as not just the domain of health. And that's why I know only 17% or 17 individuals responded, but I'm curious for those that are not in healthcare where they're coming from, because we need you now more than ever to really think about how we can increase investment. And also, I think the community stakeholder approach is such a valuable foundation, and I'll just flesh that out with you. There's a field, for those of you who are familiar with community-based participatory research, really grounds itself on the idea that that scientific knowledge does not come solely from the academicians, but comes also in a very democratized approach from the individuals who live those experiences day in and day out, and they become equal participants in the research process. That is how we frame our research questions, in the hope that by having that information from the get-go, that you'll be able to adapt interventions, first develop them, and when already evidence-based, adapt them in a way that will more smoothly glide into implementation. And there's this, what's called quality chasm, which is the 17-year gap from the development of an evidence-based intervention into actual uptake into practice. So I think what we've strongly seen from the HIV epidemic, and let's give the case study of the United States, where we have tremendous control of the virus, except when you look on the disaggregated data by race and ethnicity and gender, you see tremendous disparities particularly in the Black, African American, and Latino populations. So the needed activism and insight from these populations are key so that we can get what is known to be efficacious, like antiretroviral therapy or pre-exposure prophylaxis, into the individuals that need it. So I think, thinking about consequences of this is also who we're bringing to the table, and using this whole of society approach is going to be key.
That links really nicely, Julie, into one of our first questions. I should say that we're not going to be able to answer all of these questions, but if lots of people ask similar things, I'll try and pass them on to Julie and Ruanne. And so Trina Shanks asked right early on, do you think the emphasis on race and ethnic disparities will lead to greater resources and concern, or stigma, blaming, and disengagement?
Well, I think that key in this is where the power is for change. And I think that, the more that we have not only stakeholders or affected populations who are part of the policymakers, who are part of the scientific teams. I know both Ruanne and I collaborate with community advisory boards. I think if we integrate and our affected communities into the response, and not only integrate them, but acknowledge them as equal partners, I think that we are have a better chance of really using this as an actionable lever. I think we also have to hold up and give press and voice to those individuals who are really not only speaking from evidence-based and scientific knowledge, but one of compassion. One of the things that we've certainly learned with HIV, but also with sexually transmitted infections and many chronic diseases for which there is no treatment, or their causes confusing, like cancer, tuberculosis, individuals become defined by their disease. That's been one of my concerns with this warlike mentality with COVID. I think that is in some ways unifying, but on the counter argument is the negative connotations that occur when we negate what what this virus is, which is an infection which needs a systematic process to control it. So I think that as much as we can be aware in our language and in the spokespersons who are bringing these messages to our populations, that this is a response of compassion, of solidarity, not of fault or blame, that we'll be better off for making sense of the data.
And I just want to emphasize Julie's first point, that this is the structural inequalities in our society. And this is a time for us to shine light on that the inequalities that we see for COVID-19 outcomes, infections, deaths, is a larger systemic picture. And this is really a time for us to use all we've learned about that and the progress that we're making as a society to shine light on this and move forward in a way that will not exacerbate the existing disparities, and start thinking about what we are doing to fix them.
On that sort of thought, I'm starting to feel more and more uncertain, and like I know even less about what I can do, what we can do. So perhaps in the knowledge that 60% of our attendees said that they are other, we've got some healthcare workers, policy scientists, and some future healthcare workers in this bunch. Where should we as a community, as individuals, be trying to have an impact on these broad issues you're talking about, which stretch beyond COVID even?
I think one of the first parts to recognize is the importance of our own individual behavior, which starts in the choices that we make in our own families, and the support that we give for friends. I mean, I can't underscore enough how I think we can all share this experience, how complicated physical distancing is. It really requires a broad mutual aid society to be able to get through that. So I think one of the things that is so challenging about this moment is an emerging infectious disease. Presents great anxiety for individuals because we feel uncertain about what we can do that's actionable and efficacious. But the data are clear here that physical distancing impacts this condition. So then, for all of you who take on an operational science approach, I think it's helpful to break it down into those small components. What are the barriers and facilitators to getting that part done? And not only is that in our own physical space, but then the people who are dependent on us, and that extends into the workplace. So then we begin to think about workplace policies and how those are exerted either equitably or oftentimes unequitably. For example, one issue that has arisen and that our hospital has been very transparent about, we initially established a health equity task force, and it was clear that, for example, individuals transport differently to the healthcare setting. A large part of our workforce uses public transportation, particularly individuals of lower socioeconomic status. So it was clear that we had to acknowledge that. We had to protect workers, whether it was by counseling them in how to create or obtain masks. But I think, thinking about the operational challenges to getting to the outcome is one way of breaking this down.
Thanks, Julie. And I can add that everyone has agency, and so use the skills that you have. Send emails, talk on video, and write letters to the newspaper. If you notice something that isn't the way it ought to be or is not evidence-driven, highlight it. I think that is something that we can always do. Bring attention to questions that you think are exacerbating underlying inequalities. So in your own behavior and in the community around, in the communities around you, in the communities you already belong to, think about these questions. And then I think the other important thing is ensure that you are reading and listening and thinking about evidence, and that you have a diversity of viewpoints. So here in the US, the governor of Ohio, a Republican, one of the very first people to, one of the first governors to institute outstanding measures to mitigate COVID-19. They very early on, they limited travel and closed schools and had physical distancing, and as a direct result of that have had fewer cases. And of course, this was not a politically popular decision, but when interviewed about how he came to that decision, and it differed quite widely from other Republican governors. He said that he learned early on that when he made mistakes, it was usually a result of not having enough information. When I read about it, I immediately made the resolution that I'm going to ask more questions, and I'm going to look for more evidence, and I'm going to ensure that I have I think he called it a brain trust in opinions that he was listening to and information that he was using. So I think that being conscious that we want a diversity of views, that we want experts, that we want evidence, and that we're going to search widely and be attentive to that is something that all of us can do. And we have incredible access through the University of Washington, through the libraries and online journals and our colleagues. And as members of this community, it's also our responsibility to do that.
May I ask a question to both of you to back that up? Because you're talking about needing to have information, and we've got some quite specific information questions here. What I might do is give you a few of them all at once with a combining question. So some specific questions, thinking that you're both public health physicians and ID physicians. We've got, is nationwide testing possible or recommended? Why are reliable antibody tests harder to develop than antigen tests? What do you project will be the trends for COVID-19 in low and middle income countries, especially sub-Saharan Africa? There are suggestions that warm weathers and widespread BCG vaccinations and background TB exposure could mitigate disease escalation in that region. And I'm going to add a bonus, in fact, two bonuses from Michael Anderson. For governments facing budget constraints, do you think they should be prioritizing antigen testing or antibody testing? And I'm going to add a further one. So we've got some questions about tests specifically, about projection of what might happen in low and middle income countries. And the bonus is, where should we be looking for information?
Oscar, for your last question, which information were you thinking about?
So, considering that we have a variety of people in the audience here who are obviously interested in having more information about COVID-19, considering that there is a lot of information out at the moment, including some very good information and some very bad information that my mother tends to send me, where should we in the audience be looking for information?
I think the nationwide testing, just to start there, is key. And we can look at examples of countries such as South Korea and Singapore that did that expeditiously, were able to identify cases and break the links of transmission. That's where in the US we've really been handicapped, is that we have not been able to ramp up testing for a number of reasons, and moved fairly quickly to a physical distancing style approach because we've lost control of links of transmission. So certainly we need testing. There are pitfalls to both the antibody and antigen testing to really understand infectivity. But one thing that I, can't emphasize enough is, and I think, Ruanne and I would love to think more with Ruanne and those on the call about this, is bundling testing with the components that are needed to get the outcomes that are desired. So, for example, there are a lot of assumptions within testing that individuals, in the majority of cases, who will be mild or not requiring hospitalizations, that people, like I had mentioned before, can self-isolate at home. That's a major assumption for a number of reasons, even under the best circumstances. But you can imagine, like I had mentioned before, close contacts at home, the ability to have enough food for 14 days. Food insecurity is a major, and housing are major concerns with self-isolation. So when we have testing, and I should just say that, the big criticism around HIV has been called the test that leads to nowhere. So where is our SARS-CoV testing leading to? And so if we have testing, we need to be clear as to what the disposition of individuals are. And if individuals are not sick enough to go into the hospital, and they are not safe enough to live at home, then we need to have facilities that can monitor these individuals. And that's an area that we've also been slower in ramping up. And so one of the issues that we've had are patients who are self-isolating at home but are not able to really cope in that setting. We are just in the last week or two getting facilities up. Most of them are for patients who are already have COVID-19 disease but don't need a hospital setting, but there's minimal housing facilities for individuals that need to quarantine but don't need an acute care setting. So I think we really need to think about this testing flow a bit better for patients, so that we're really leading them to the direction where we want them, which is to be able to have someone who can check in on them or be monitored, and that they can minimize their physical contacts. Ruanne, maybe you can, I don't know if you have some thoughts about that. I have like the 4 or 5 questions, but I don't know if you have any thoughts about what I mentioned.
So I think access to testing, as I learned to say when I moved to the US, is a no-brainer. But there should be nationwide testing. It should be available. In the absence of that evidence, we really don't understand what is going on. As Julie said, we don't know who's infected. We don't know how infectious people are within their households. We don't understand what the duration, how long people are infectious for. So we really do need to ramp up the science here so we understand what is going on. Regarding antibody and antigen tests, the antigen tests were the first ones that were developed because there were no people who had recovered from the disease at first, in order for us to develop the antibody test. That I had a Zoom meeting with the lab 2 days ago, and they were reviewing the first antibody test. So I think we're just a short time, days, weeks at the most, away from reliable antibody testing. Regarding which one is more important, antibody or antigen testing, and so antigen is from the virus itself, so it shows you have current infection. And antibody testing shows that your body has responded to the infection and mounted a response. Both are necessary because they provide different information, and we really can't skimp on this as scientists. There are ways that we could do representative testing, but this is an area where we do need to scale up and make this much more widely available. Yeah, so I'll stop there for testing.
Maybe elsewhere I can, and I'm interested also in Ruanne's perspective, having come from South Africa, and I've learned a lot from Ruanne in this space, but thinking about low and middle income countries. I mean, one, of course, concern that has already reared its head is about access to materials, to PPE, to swabs, to the necessary technical aspects in terms of sharing of resources. I think is, I think it from a diplomatic perspective, there are great questions about what our interdependency is about. I mean, clearly, as a globe, we are all suffering in this to differing extents, and it raises, I think, important issues about how we share these resources and the benefit of scientific knowledge, and how we think about testing. You know, the issue about vaccines. That we're really thoughtful about the populations that we're testing vaccines in, and that we're engaging those communities. That we're not thinking that this is some other population's problem and we're going to test abroad. I know that those ethical concerns have already been raised. You know, the other issue in the US, but I think this mirrors itself in any sort of urban-rural dichotomy, is thinking about delayed waves of transmission. There are certainly areas, rural areas, that have a later presentation of COVID. We want to continue to emphasize that those transmission waves are yet to come, and really being able to proactively reinforce resources in rural areas so that they're capable of responding. I think we'll have to think clear, you know, together. If we have time, Oscar, I think the issue about evaluating evidence and where one gets knowledge is key. Misinformation is abound, and this is an age where peer-reviewed publications are, of course, key, but data are coming out much faster than the capacity to peer review. I think academic medical centers are important sources of information where we can try to curate evidence-based messages. And then I think bringing that back, I keep talking about community, but using social influencers and peers to bring that message back in a way that makes sense on a local level.
I'm aware that we're running out of time, and we have on the Mentimeter a last couple of slides which are about feedback and are an opportunity for you to be able to give comments directly to Julie and Ruanne as well. So please do complete that before you finish. And before we finish that, I would really like to ask Julie and Ruanne both, in 1 minute, what would you like to say to everyone in the audience? What would you like us to take away from this session?
So, I think the main departing message that I want to leave everyone with is that this is a moment for hope, and it's a moment for us to see the opportunity in this, to do good science and compassionate care, and to take all the training and expertise that we have and move forward with edge and embracing a diversity of viewpoints.
I would echo that to underscore the importance that we're seeing of public health and infectious diseases and our global interdependence. I can only underscore what Ruanne is saying, that there is tremendous optimism. I think, I'm not saying that as a naive person, I think it's our only way forward. This is a tremendous opportunity that we've been given to re-engineer and reimagine what a more mutually interconnected world we could have. And it's not just going to be, of course, health stakeholders. It's going to be all of the facets of society. So I would just invite further conversations about how we think from economics, banking, finance, to think through this contagion as an example of the next emerging infectious disease, which will come. But we have an opportunity to strengthen ourselves here.
Thank you very much, Julie. And thank you very much, Ruanne. I know how busy you are at the moment, or I have an idea of how busy you are at the moment. So I personally very much appreciate you giving us the time to give your insights on what your experience has been like and what you're understanding from your much more knowledgeable perspectives than most of us have been. I'm going to share the last slide of our presentation, which will be the best opportunity for you to be able to give direct comments and feedback to Julie, and to Ruanne, apologies. So if before you leave today, you can please go to menti.com and use this code, that will give us a chance to be able to leave comments and to leave feedback for Julie, for Ruanne, and for the process. So thank you very much, everyone.
Thanks very much, Oscar.
Thank you. Be well.
Yes, it was wonderful to do this. Thank you. Bye-bye.